Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky. I got my co-host, super endocrinologist, Dr. Karl Nadolsky Jr.
Hello.
And we wanted to, we actually had a week off, if anybody even noticed.
Nope.
No, nobody cared.
Noticed.
Nobody cared. Today we're going to be talking about these new guidelines that just came out, talking about the new guidelines about obesity medicine. We've talked about this all the time already on podcasts, but we're just going to go through them quickly to see if there's anything new. And then we're actually going to discuss some of these new indications for getting surgery for weight loss. We already had our podcast with Dr. Garth Davis, a bariatric surgeon and vegan, super vegan, who went over the indications, but they've actually updated the indications, something we alluded to in that podcast. And then we want to start this off by actually talking about something we're seeing in the news, talking about Hollywood movie stars using these extremely expensive, however highly effective medicines for weight loss that's not indicated, meaning these people don't actually have obesity or overweight with comorbidities or anything like that. They strictly have some vanity weight that they're using these powerful medicines, specifically Ozempic, it seems like, to the point where I'm trying to prescribe it for I've actually had to switch patients off of Ozempic because they can't get it at least at the 2 milligram dose. For me, they can get it at the 1 milligram dose, it seems like. But anyway,
well, this is this is a bigger problem all around. I mean, the whole country and apparently even globally. And so these little things just exacerbate it. So for just some context, if you haven't listened to our obesity medication podcast, you should go back and listen to that at some point to know what we're talking about. But semaglutide, the generic name for the molecule that is a weekly shot, which mimics our gut hormones called incretins, is really good for appetite, essentially suppression, and satiety, thus really good for weight loss, and initially was indicated for type 2 diabetes under the trade name Ozempic, which is what Spencer just mentioned. And originally, that's how I
Ozempic.
My whenever I tell my patients that, they probably think I'm a complete just out of my mind, because I'm like, have you ever seen the commercials for Ozempic? They're like, oh yeah, that one. Anyways, it's a weekly shot, mimics intestine hormones, works up in the hypothalamus where we have our appetite regulation center, and is really, really, really good at helping people adhere to their dietary efforts, lose weight, and then it has some other mechanisms that are very good for diabetes, for sugar control, and also has cardiovascular outcome data, meaning it's good for reducing your risk of cardiovascular events like heart attacks and strokes. So historically it was approved at 1 milligram a week for type 2 diabetes. Then last year was approved up to 2.4 milligrams under the trade name Wegovy, and that's really what started the big media frenzy, I think. Right?
I think so.
I mean, it was everyone was waiting for it. We all knew the data, and then it made waves. And unfortunately, due to, I kind of know some of this, but I don't know that we need to get into the weeds. But they had a different device. That manufacturing of that different device than Ozempic had some issues, and over the past year, we've had now supply chain issues with Wegovy.
Yeah, you can't even get Wegovy unless it's at the higher dose.
Right. And so anyway, so that's caused a problem. So then, because people could get Ozempic, and anybody who has obesity and type 2 diabetes certainly has the indication for Ozempic, just because it's technically only indicated for type 2 diabetes. So it was being used even more. And then it got approved at the higher dose, 2 milligrams, which is a lot closer, of course, obviously, to the 2.4 of Wegovy. And it's the same exact stuff. And so then it was also being used a lot off-label. which is essentially what you were just saying for the Hollywood stars, even though they don't have the indication for anything. I mean, they don't have obesity. Remember, obesity being a disease of excess, abnormally distributed adipose tissue that causes health problems. And so it would be like us saying, I'm struggling to get ripped more, and so I'm going to use this just to get
tiny
shredded.
Little dose, maybe a little 0.25 milligrams. I don't know.
So I don't know do you know anybody who's admitted to using it? I think I saw some names from the Hollywood.
They're throwing
circuit.
out names. I don't think we probably don't want to get sued.
Yeah,
because we don't know. Like, we've been asked to be interviewed for these things. We saw a few of our obesity doctor friends tweeting about it. I got tagged a bunch of times. We just wanted to address it right here. Like, these medicines should be. I do use Ozempic for obesity for my patients where it would be indicated otherwise for Wegovy, since Wegovy is out of stock. However, I did for people that are using it for vanity purposes. I mean, the one thing is, I sure as hell hope insurance isn't paying for that. Number one. But
the Hollywood people, they're paying for
it.
Sure,
they should be paying cash.
But still, now what has happened is now there's a supply issue for people who really, really, really need it. People with obesity and type 2 diabetes and
severe obesity with comorbidities and that type of thing.
Yeah, and it's amazing. You and I even debate slightly that I really think that these really expensive, very good medications that also will include tirzepatide for those who listen to our
my favorite.
I mean, and that's good, and it will be approved for obesity, and then there will be more. They're very expensive.
It's on the fast track, by the way, if anybody wants to know. They just
and so really, when you look at like the cost effectiveness and who really should be getting these, the more risk, unfortunately, the more health problems you have from obesity, the more benefit you get, the more bang for the buck, so to speak. So not everyone with all simple, and it shouldn't be called simple, but uncomplicated obesity, we'll call it, necessarily should get these. But boy, then at least we can debate that. We shouldn't be wasting it on people who just need to lean up a little bit. So anyways.
And there was a report recently about the cost effectiveness of these medicines. It needs to come down. It just does. Well, I think I prescribe these a lot. And in my opinion is that with competition, with these newer, there's, in fact, I just got a DM from a patient, not my patient, a person, I think they're abroad, who is using a GLP-1 glucagon peptide combo
in a trial. Yeah.
And they are
he doesn't know. He doesn't know if he's got that or placebo. He thinks he does because he's losing.
They've lost a significant amount of weight and have their cravings are blasted away. So
that's awesome.
If tirzepatide, by the way, is the one, which is GLP and GIP, they've also put together GLP and glucagon together in a peptide. It's fascinating stuff.
And we know that semaglutide has been studied in combination with something called cagrilintide, which is an amylin analog. Which is another hormone that comes from your pancreas. Anyways, and that's going to be really great.
Anyway, I think with the competition, the prices will come down.
Hopefully.
They have to. I hope so. Either that
it's supply and demand stuff,
they can't screw up the pen. How do you manufacture the pen that actually injects this stuff? Really interesting stuff. Anyway, that's that. Let's get into these new guidelines that just came out of the American Gastroenterology something or other.
Yeah, the American Gastroenterology Association developed these clinical practice guidelines on the pharmacological interventions for adults with obesity. So a lot of people out there might say, well, why the heck are the gastroenterologists doing this? Well, they get into, first of all, we all need to be doing this, all of us together. And the gastroenterologists also do some of the procedures that we haven't really talked a lot about that are being studied for obesity. And so
we should get somebody on to talk about that. A gastroenterologist.
Yeah, absolutely. We should. And I actually, due to some other projects I was doing for some organizations, actually reviewed these guidelines a couple months ago before they were published to give feedback and talk about endorsement and all that stuff. And the interesting thing about it, they are very straightforward and simple because they're done, through the grade methodology, which is basically, people don't necessarily need to worry about that too much, other than it's a very standardized way to do systematic reviews to answer very specific clinical questions that we call PICO questions, patient, intervention. Now I'm drawing a blank on of them. Patient population intervention outcome.
Whatever.
Drawing a blank. Anyways, doesn't matter. And then what you do is then you have the methodologists do a very good literature search for the studies that go into these questions to answer the questions, and then you have a team of experts that go through them and you grade them based upon the strength of the evidence, because there's all sorts of stuff that goes into studies that make them reliable, less reliable, and whatnot. And so the bottom line is that these studies, or this guideline, did that, and they came up with essentially 9 pretty basic recommendations based upon when to use these drugs.
Let's hear them.
All right, let me go.
I know that they talked about not using orlistat. They did.
They said
I know. Not to use orlistat.
It's interesting, and we can talk about.
I still prescribe it, as we talked about in our GLP-1, because I still use it for my GLP-1s. I did. So one of my patients says it was working really great, and then it worked too great. I shit my pants. They literally said that. I was like,
sure. And that's sorry. Now in the chart. Yeah. Well. And that happened. So anyways, number one, and you can imagine the question that went into this was, should people with obesity get anti-obesity medications? And so, it says adults with obesity and weight-related complications. So again, this is not just that stage, like uncomplicated obesity. And then here's a little caveat. It says, who have had an inadequate response to lifestyle interventions. The AGA, American Gastroenterology Association, recommends adding pharmacological agents to lifestyle interventions over continuing lifestyle interventions alone. And you grade, you talk about the strength of these recommendations. So it's a strong recommendation. It uses the term recommends as opposed to suggests, which is a little bit weaker of a recommendation based upon pretty moderate quality evidence. I guess to most of us, well, duh, that's obvious. And so the thing is, these guidelines are based on really just absolute finite randomized controlled trials. So we know that all of these anti-obesity medications that are approved were approved because they help absolutely above and beyond what lifestyle interventions do, because it's hard because of the complexity of the disease. So, that is a little bit of a, I don't know, silly thing, I guess. So, it is what it is.
Right.
But the key to this is it helps, not only clinicians, but it helps everyone know that, okay, this evidence was reviewed in such a way that anybody could have reviewed the evidence. It doesn't have to be experts in the field.
Yeah.
With a methodologist and people answering the basic questions, the evidence says, yes, specifically if you have complications from obesity, absolutely pharmacotherapy should be used. Now, some of us would argue that, when it says have had inadequate response to lifestyle interventions, well, most people have been trying to some degree their whole lives.
The majority of people.
And so some of us would argue that, I don't know. I don't know that is necessarily the best thing. We could debate that. And
we've talked about this before.
Because a lot of people just need it up front.
Right. We've talked about this before. But most people have tried 10 times. The people that come to me, I survey them all.
Yeah.
And they've tried the keto, they've tried the paleo, they've tried the South Beach, they've done low fat, plant-based, whatever. It doesn't matter.
Yeah. They're all trying to exercise. Now, if you go back and look at our 2016 ACE guidelines that I helped out with, we talked about, hey, if you have obesity with complications, you really need to, at least discuss these medications and think about them earlier on and upfront. So that's the basic one. And then it goes on and it goes through like each medication that's approved. And so then it says the AGA suggests, again, this is not as strong of a wording, using semaglutide, that's the Wegovy, at 2.4 milligrams, with lifestyle modifications compared with lifestyle modifications alone. And then it goes through a few little things to think about how...
My guideline would be like, I command you to take this semaglutide.
Okay. That's because you don't care about the cost effectiveness.
No.
Anyways, because they're looking absolutely very strictly at these randomized controlled data, and we know that people with complications absolutely get the most benefit for bang for the buck. it does give a few little nuggets that, we all know about titrating it slowly and all these things, and about the great benefits for type 2 diabetes. But it also, it makes this little point to say GLP-1 receptor agonists have been associated with increased risk of pancreatitis and gallbladder disease. I guess I just want to point out that really, when we look at all the studies, they don't really seem to be causally associated with pancreatitis like everyone was fearing about. But there was that big meta-analysis recently that does show a little bit of a true increase in gallbladder disease. I don't know if you've seen much of that. But
no, we talked about that too. I think it's likely the weight loss, but there could be a very small effect on the gallbladder motility. I don't know.
Yeah. It's certainly not a reason to avoid them, but it's something to be aware of for patients and doctors and everyone like that. Yeah. It goes on to then use the daily, talk about the daily liraglutide 3 milligrams, which is essentially the daily version of semaglutide or Ozempic and Wegovy. And it really kind of says the same stuff as it said for the semaglutide, but we know that semaglutide is much more
twice as
powerful.
It's about twice as effective as liraglutide, or
for the weight loss, especially
for weight loss. Yeah.
Then it goes on to talk about the phentermine topiramate extended release, and again, it says the same thing. Suggests using it, compared with lifestyle modification alone for people who have weight-related complications. And then it makes a few little points that are relatively, well known, like it may also be effective for migraines because of the topiramate. That's approved for treating migraines, and so may be preferentially used in those people. It does say to be avoided in patients with a history of cardiovascular disease and uncontrolled hypertension. I'd like to see how they graded that exactly, because it wasn't studied in people with cardiovascular disease. It's all a little bit based upon the semi-fear of phentermine, even though we have a lot of data showing that if you respond to any type of intervention and get more than 10% weight loss, you reduce your cardiovascular risk. So
I mean, and what does that even mean? We were talking about this. We're putting together a paper for something else, and talking about, like, what does that mean? What's the definition of cardiovascular disease?
Right. Well, that could mean
are they saying they've had
an
event? Are they had an event, meaning they had a heart attack in the past? Do they have a little bit of coronary artery calcium, just a little bit?
Well, right. There's a wide spectrum.
There's a lot. We're going to have some cardiologists on.
Generally, what it means, I think, is people who've had a heart attack, a stroke,
if somebody's had one of those,
they have stents. They got enough symptomatic disease that they had an intervention done.
If that's the case, I think that needs to be delineated. And if that were the case, I personally would not prescribe in those patients, just for the hypothetical concern. But if somebody has subclinical atherosclerosis, which some might consider they have,
probably a lot of our patients do. So that,
I know,
and that's the thing.
Exactly.
So obviously we don't want to fall down a legal slippery slope or anything, but it's
right.
I just don't think there's any evidence to show harm.
I don't think so.
But anyways,
I don't want to get sued. So
exactly. And then it goes on to talk about the naltrexone bupropion extended release, which is Contrave. Says the exact same thing. Suggests, and compared with lifestyle modification alone in people with weight-related comorbidities, it does, make a little mention of, well, maybe this could help with people who are also attempting smoking cessation, because this medicine is really good for some of those sort of addictive hormones in our brain that work against us. And in patients with depression, you have to be really careful about that, but it's something you could ask your physician about if you're struggling with all these things, because of the bupropion is pretty well-established medication for depression. But there's also some concerns with that too. You don't want to mix it with other ones, and it can worsen sometimes. It can lower the seizure threshold, so it makes a note of that if you have a history of seizures.
It all around is the least effective of all the ones approved right now.
But certainly some people really do respond to it. Well, if you have if you have the cravings, you have that feeling of like food addiction, those are the people who do respond. And then if you do respond to it, then people do really well. And so, it's just not as across the board as efficacious.
In my experience right now, it's either they get like nothing from it, or they respond extremely well, and it's few and far between that respond, as far as I can tell.
Just something to think about. And then here's your orlistat one, and so it says in adults with obesity with weight, and it does come back to this weight-related complication. It says AGA suggests against the use of orlistat.
That's interesting.
With a little comment, because patients who place a high value on the potential small weight loss benefit. Now, we did talk about it. It has some reasonable weight loss benefit. It really does. And it's not that bad. It's just compared to some of these newer ones, phentermine, topiramate, and the GLP-1 receptor agonists, it doesn't. And so so the small weight loss benefit and a low value on the GI adverse effects, it kind of reverses it around. It's basically saying, well, if you really, really want that small benefit, but you don't really care about, like you said, shitting yourself with oily stool, then maybe it's reasonable. And so it definitely has its place, I think, in certain people, but we don't really use it that much first line. Absolutely. It has to be taken 3 times a day with meals. You get oily stools, fecal incontinence. And, while
Sounds
it has
wonderful.
A lot of benefits, you got to do it with a low fat diet. We do tend to probably, even though we make fun of keto, we do tend to cut carbs more. And we'd like to encourage Mediterranean diets, which has a lot of olive oil and fatty nuts and seeds and fish. And anyways.
Yeah, I do think it should be reserved. I mean, we might want to talk to somebody to get a study, adding it in with one of these GLPs people that have constipation specifically, because it does. My patients come back. I've put maybe 20 people on it who have constipation. They're like, oh, well, that helped.
Yeah.
Except for the one person.
And then the one guy.
Yeah. Which was
I wonder if he's listening to this. He's going to.
He might. Right. I don't want to. Yeah. I don't want to HIPAA this. But.
Yeah. But hopefully he's entertained by it.
Yeah, for sure.
Okay. And then it goes on and it talks about some older medications that are only approved for 12 weeks at a time. Phentermine by itself, which again, we always talk about, doesn't make sense because it's been studied long-term in combination with topiramate. But just because it is how it's FDA indicated, it suggests using phentermine compared with lifestyle modifications alone. But it makes a point to say that it's approved for only 12 weeks. But that many practitioners, if you're in a state that it's legal, certainly use it longer than 12 weeks in a quote unquote off-label fashion. So, and it goes, and it talks the same basic thing about diethylpropan, which is similar to bupropion, but I don't ever use that.
I rarely ever use that. I don't anymore because I'm online. I can't but I never use that in the clinic.
And then here's a funny one for you because you always make fun of this one. So, we've talked about the super absorbent hydrogel, the Gelesis, which I'm kind of glad they put it in here because I know I want to include it in our guidance for medications, even though it's not truly a medication. It was approved by the FDA. Yeah, which is why it didn't need to have such robust clinical trials like medications do.
I think we should come out with a device.
Well, yeah, we probably should. And it just get approved without anything.
Yeah.
So it says, and so Gelesis is approved for people with a BMI between 25 and 40, whereas everyone else is a BMI of 27 plus comorbidities. But it recommends using Gelesis 100 oral super absorbent hydrogel only in the context of a clinical trial, probably because it was approved as a device, didn't need that many trials and data to go into it. So it really is very it's very minimal compared to the big drug trials.
Yeah, that's
we talk about them all the time. It also has its place. It has its place. Especially I think it has its place for people who have relatively mild excess adiposity, obesity, but without any complications.
This is the one that the people should be using for vanity.
Yes, exactly. You're right. Yep.
That's the one.
Yeah.
Go ahead and waste your money on this.
Yeah. So that's the basics of this guideline. Obviously, there's a lot more that goes into it. It's available for free for the other nerds out there and the other doctors that want to read through it. And it does nicely go through all the evidence of all the randomized controlled trials of the drugs, the pros, cons, the strength of the evidence. But that's basically it.
Cool.
So it's not really changing what we're doing. It's just kind of reiterating it and accumulating the data for us.
If you want to know more about each of those drugs, we had a podcast on pretty much each of those. So we just wanted to highlight this new guideline because it's new. It's the newest one out since yours in 2016.
Yeah. And it is a true clinical practice guideline using this grade methodology, which is standardized across the world, very strict, basically showing that, yes, these medications help people lose weight and improve their weight-related complications. That's really kind of the key. That's what it does. They absolutely reviewed it. Anybody who does any review would agree. That's how these grade methodologies
including TikTok commenters and Twitter.
Yeah. I guess you have to know something about something and how to do methodology.
Something.
So
okay.
So all right, one more thing.
Yeah. So then the next thing is the surgical indications. So in our first podcast with Dr. Garth Davis, bariatric surgeon, we talked about the indications of bariatric surgery, which, some people are like, this is barbaric surgery. You're realigning people's intestines and cutting them open and killing people just to help people lose weight. It's like, no, it's extremely safe and extremely effective. Mm-hmm. The indications we talked about were a 40 BMI and above, or a 35 BMI plus comorbidities such as hypertension, prediabetes, type 2 diabetes, obstructive sleep apnea, that type of thing.
Yeah.
They've updated. Who is this? The American?
Well, yeah. So, but that was the problem is that was based upon the National Institutes of Health consensus conference
in 91
that published a statement in 1991, 30 years ago.
Wow.
And so, yeah, I mean, it's kind of crazy. And so that's what the insurance companies have been going on all these years, even though the American Society of Metabolic and Bariatric Surgery and the American Association of Clinical Endocrinology came up with bariatric surgery, metabolic surgery guidelines several years ago, which I think that was 2013, the first ones that they did.
Oh.
Those were updated in 2019 and based upon all the evidence of that time, talk about, hey, anybody not only over BMI 40, but also 35 in comorbidities. And we should start really considering surgery for those with a BMI of 30 and type 2 diabetes who are struggling. That was actually based upon a huge international joint consensus statement that included, American Diabetes Association, International Diabetes Federation, the European Association for the Study of Diabetes, all those who said,
I'm pretty sure we're at the conference when they talked about this. I'm pretty sure we were there.
It was
right before
it was
COVID,
a few years ago. Yeah,
right before the pandemic.
Yeah, because it was 2019 when it was published.
And we met McDreamy.
Yeah, that is when we. Oh my God, maybe he's listening to it.
I hope. Yeah, Patrick.
We should tell that story.
Please, Patrick Dempsey. We went to the obesity week, and we were
3 years ago.
Oh, it was right before the pandemic. Right before all this stuff. Anyway, we were leaving the airport from Las Vegas. And my brother, Dr. Karl, he goes, "Oh my God, is that Dr. Shepard?" And I was like, "What?" And I was like, "Oh my God!"
He was all by himself, talking to his assistant in a.
Yeah, and he was trying to figure out where to go, and my brother was like, "Let's go talk to him." I'm like, "Please don't bother him. He's probably."
Spencer seemed so embarrassed.
I was like, no, please don't. And he goes, the hell, we're not saying anything. He goes, Dr. Shepard, Dr. Shepard, and he waved him down, and he looks over, and
he looks over, he goes, "Yes."
Yeah, he goes, "Yes."
We go, "Dr. Shepard," and he goes, "Yes." He looks at us very, like he knew exactly who he was, and then he was the nicest guy in the world, and we got a picture with him, and then he goes, "Hold on, wait, turn this way."
Yeah, he goes, "No, turn, hold on."
He knew the lighting so well, and then not only did he get a beautiful picture of himself because he's such a beautiful guy, we actually look pretty darn good in that picture too.
Yeah,
well, I'll share it with this podcast.
He was extremely attractive.
He was.
I was just like,
good-looking guy.
And
it's really nice.
I don't think I get starstruck, but it was weird because I was like about shaking my camera going, "Oh my God, this is like the guy that I watch on TV all the time."
All right. Anyways.
Except they killed him off. I don't know why they did that. But anyway.
Better stuff to do.
Anyway, great guy.
So God, I don't know how we got off on that. Anyways, that was when that was published. And they talked about if you have a BMI of 30 with type 2 diabetes, the evidence really shows that bariatric and metabolic surgery is beneficial. So what this is now, and actually then the American Society of Metabolic and Bariatric Surgery kind of re-upped, sort of, had another statement saying, hey, we got to lower these BMI thresholds. This is not a BMI-centric disease. Obesity is not. And so then this is jointly with the International Federation for Surgery of Obesity and Metabolic Disorders. And so this isn't like a guideline or anything, but it's a statement on the indications. And so the major updates essentially are that metabolic bariatric surgery recommended for individuals with a body mass index of 35 or greater, regardless of the presence, absence, or severity of comorbidities. So they've lowered that. What they're trying to say is, hey, we really need to lower that threshold from 40 to 35 to get coverage. And that seems right. Then it should be considered for those with a BMI of 30 to 34.9 if they have adiposity-based chronic disease complications, obesity complications. And now, we could debate on, well, what have they tried, between diet, exercise, medications, all these other things, but it's indicated. It should be indicated.
It's a strong tool. The thing is that if you go back to our podcast, we discussed this before, people think these have high complication rates,
but they don't.
Really don't.
Yeah, they don't. There are a few caveats, but they don't.
I'm a medical obesity physician, so I love shilling out, these new meds. But having said that, these powerful, surgical tools, it's a much more permanent. You don't have to keep taking a medicine. Yeah. Having said that,
you have to keep up your your nutrition efforts and your exercise. So
it's only a tool.
The other thing that I think is important to note is that just like other things we've talked about, they mentioned having lower BMI thresholds for the Asian populations because we have a lot of evidence to show that with a BMI of 25 or greater, that likely suggests clinical obesity. Obviously everyone's different. And then if they have a BMI of 27 and a half or over, they should be offered metabolic bariatric surgery. They make a point to say, the long-term results consistently demonstrate safety and efficacy. And that is true. I mean, there's just been so much data to show the reduction in not just the weight, because that's not what matters. It's the weight-related complications and likely reducing, mortality, like extending people's lives.
Decreasing rates of cancer, all sorts of things. I mean, this stuff's pretty hard to do an RCT, but the observational data looks pretty good.
And they're working on RCTs to some degree, and they always end up showing great outcomes. So and that's the basics of it. This is free. There's going to be a lot of media on this, for the lay public. Hopefully the media don't screw it up like they often do. No offense to the media. But that's basically it. Anything
I think
else?
it's a good thing. Yeah, no, I think it's good to point out that these tools, the thing is they're underutilized regardless, whether it's medicine, unless it's going viral on TikTok or something, plus these surgeries. And I think it's still the stigma and the biases of not only PCPs, but even specialists that hopefully if they're listening and if you're a patient, you can advocate for yourself saying, hey, I meet this criteria. I've been struggling. Please help me out. And hopefully you get to somebody that will help you out. But of course, if you want to look into the medicine, you can always come see me or my partners online at joinsequence.com, or you can go visit my brother in Michigan. He'll take good care of you.
Up in Michigan.
Go see Dr. Garth if you want to get some surgery. He's got a center of excellence.
And we do have lots of colleagues who do great work around the country and around the world. So if you need help,
good.
Help's out there.
All right. Well, that's it for this week.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.